In this segment, I'd like to go over the Explorer positioning that I do when I do a full mouth debridement. So I'll just kind of be talking through what I typically go through. I normally start out on the upper left, and we're using these magnetostrictive ultrasonics, but that's explained in other segments as to why we use these. But I'll go and anesthetize the entire upper arch using articaine infiltration, like a third. Sorry, my microscope slipped there. A quarter, a third. And that pretty much numbs up the entire arch, including the palatal aspects. If there's really deep palatal pocketing and I don't want any question about the anesthesia, I will do a greater palatine block with articaine. Maybe just a stopper of a carpule. So the patient's anesthetized, and I normally get the patient positioned and start in the upper left, kind of looking away from me so that our saliva ejector picks up all the water, because there is a lot of water with these procedures. We bend the saliva ejector in about like a horseshoe or a snowshoe shape, and place it on the retromolar area of the upper left. So I typically do a tactile debridement, go around and clean calculus, and flush out plaque and dilate pockets on 2 sextants, facial, or I go palatal and then I'll go facial. And then I start doing my endoscopic debridement. This is the left Explorer. It looks to the left. There's a shield, again there's this shield, and there's another video on kind of the details on putting these things in and out together. But I'm looking at the distal lingual corner, and then I'll start instrumenting, and as I'm looking behind this corner, I try to get as far as I can and as deep as I can into the pocket, and I keep pushing, and I'm actually, at this point, I'm feeling my way along, and I'm looking at the screen and watching my movements. So you can see that the ultrasonic, let me get this a little more in focus. The ultrasonic sometimes is right at the camera, behind the camera, or in front of the camera. It just depends on what you're able to see. And then I start curving around, and then a lot of times I can't get the ultrasonic in there without torquing this a lot. So what I'll do is I'll hold on to the instrument and bend and turn the handle, and this I found is a better way to better position these instruments. Okay, so now going in toward the mesial here and instrumenting into the mesial as I'm looking at the screen. Then I'll have to come out off of the screen, look in the mouth, position the camera. I don't normally do this with a microscope, but I have, for video purposes, I have to reposition the microscope. Start cleaning, looking into the distal as much as I can. I mean, you're not going to get all the way into the distal, so don't even bother. But sometimes you can see quite a bit. And then onto the palatal. If there's no pocketing here, a lot of times I'll just kind of look around, and a lot of times there's nothing. I get into this area, and I got the scope and the furcation. All the while you're seeing a lot of soft tissue in your camera view, and that's shown in some of our other demonstration videos. But cleaning in here, going to this corner, cleaning. Actually, I should be coming from the front of the mouth here. Cleaning. And I normally sit at about 11 o'clock looking in the mouth, positioning, looking at the screen, cleaning. Sometimes you have to twist these things and kind of push them into the base of a pocket. Cleaning back and forth, trying to look as far to the facial as possible and go all the way up in here, clean as much of this surface as possible. Then, sometimes I'll move the patient a little further to the left to get into these areas. You have to kind of turn your hand, the top of your hand over, and get in here this way. Clean. Sometimes the water starts kind of looking funny right here because it's not pulling in front of the camera. You have to angle up. Working a palatal pocketing. You see a lot of palatal pocketing in premolar and molar areas on smokers. I don't know what it is. That's just my impression. Cleaning around, looking, cleaning, and the further over you get toward the right, the harder it is to go in proximally. So don't even bother. Just start like mid-palatal to mesio, mid-palatal. If patients having problems with the water flowing this way, you may need to turn them more to the left, or just wait till you get to the other side.